Bismillahirrahmanirrahim. Welcome back, everyone. So this is the second presentation to cover the intraoperative practical approach of a pediatric cardiac anesthesia case, and this is about bringing the patient from the ward to theater and the management in theater. Please, if you have not seen the first presentation, I would encourage you to see this one. It is called Practical Approach in Pediatric Cardiac Anesthesia Preoperative. Now talking about bringing the patient from the ward to theater. Does my patient need anesthesia support during the transfer? For example, if this patient is on high flow oxygen, or this patient is tough and has frequent spilling, this patient has received already deep sedation and unable to maintain the airway or desaturating, or for example, if this patient is on significant inotropic support and this patient could collapse during the transfer. So if I have any concern about any of these points, I would just go and bring the patient from the ward with the team, and if not, I may just wait for the patient in theater. So now the patient is in theater, and I am going to start the anesthesia induction. What is the proper initial oxygen concentration, or FiO2, and the proper initial ventilation parameters to start with? FiO2 is usually guided by the cardiac physiology and by the target oxygen saturation that I need for this patient. So each cardiac lesion has a target oxygen saturation that we are trying to maintain for this type of lesion. For example, a patient who is a single ventricle physiology, we are aiming for something between 75 to 85. So anything above the 85 is not a good thing, and of course less than 75 is not great as well. So I maintain the FiO2 to maintain the saturation in this range. A patient after Glen coming for Fontaine, for example, this patient will have a higher saturation than the single ventricle physiology. So his target will be something between 80 to 90, even we may accept a bit higher, but this patient will not be like normal saturation like a normal child. And in some other patients, I will just maintain the oxygen saturation of more than 92 to 94%. So it depends on the type of cardiac lesion and the target I will choose for this patient. This target of saturation is suitable for this cardiac lesion, and I will adjust the FiO2 according to that. Now I need to talk a bit more about the QP-QS ratio. This is a very important concept in pediatric cardiac anesthesia, and this is to highlight the importance of ventilation parameters to maintain or to start with during the anesthesia. So what is the QP-QS? It is the ratio of the pulmonary blood flow to the systemic blood flow. So Q is the flow, and P is pulmonary, S is systemic. So QP to QS ratio is the ratio of the pulmonary blood flow to the systemic blood flow. The ideal QP-QS ratio is 1, which means that the pulmonary blood flow equals the systemic blood flow. And this is the case in normal circulation without any shunts. At any period of time, the amount of blood moving to the lung equals the amount of blood moving to the systemic circulation. Because the blood just moves like a train, and the RBCs and the blood has an obligatory pathway. But when there are abnormal communications between the right and left sides at various levels, maybe at the atrial level like ASD, at the ventricular level like VSD, and at the arterial level like PDA, this is the time when the blood may have options, and some of the blood may choose the abnormal pathway and the other blood will go with the normal pathway. For example, in case of a VSD, the blood with each ventricular contraction will have the choice to go to the aorta. I mean the blood in the left ventricle will have the choice to go to the aorta or to the pulmonary artery through the VSD. So in most cases, because the pulmonary vascular resistance is lower than the systemic vascular resistance, so more blood will choose the easy way to go to the lung, and in that case the pulmonary blood flow will be higher than the systemic blood flow, and the QP-QS ratio will be more than 1. And this is the case in left to right shunts. So if the flow in the lung or the flow to the lung is obstructed at any level, for example, by very high pulmonary vascular resistance or subpulmonary, pulmonary, or suprapulmonary stenosis, so the blood will find it easier to go to the systemic circulation. So with ventricular contraction, actually some blood from the right ventricle will escape to the other side, to the left ventricle, and then to the aorta. But this blood is desaturated. And this is a case of right ventricular shunts, for example, tetralogy of Fallot. The PDA is another example of abnormal communication, but it is now at the level of the arteries, at the arterial level. But it is actually the same idea. So QPQS of higher than 1 means higher pulmonary blood flow, means wet lung, and low effective systemic blood flow, because the extra blood flow goes to the lung is actually taken from the systemic blood flow, so the systemic blood flow will be lower than normal. So and also it will cause like more load on the heart to do more work to compensate for this decrease in the blood flow to the systemic circulation to maintain the perfusion. So the blood going to the systemic circulation is full of oxygen, but the total volume may be low, leading to low tissue oxygen delivery. So it is the oxygen is well, the blood is well saturated with oxygen, but the amount is not normal. So this will cause low perfusion of the systemic side. And this is the case in left to right shunt lesions, particularly if it is like a significant shunt, like VSD, PDA, with left to right shunt. If we have a QP-QS less than 1, which means that the pulmonary blood flow is less than the systemic blood flow, so this will cause low flow to the lungs and high flow to the tissues. But this high flow to the tissues is very deficient in oxygen and severely desaturated. And this also will lead to low oxygen delivery to the tissues, and that cause acidosis, and it will cause troubles and problems as well. This happens in cases of right to left shunts, such as a patient that has already developed Eisenmenger syndrome and high pulmonary vascular resistance, and this patient started to shunt right to left instead of left to right, and also in a patient with tetralogy of Fallot. What we need is actually a QP-QS ratio around 1. This gives the best oxygen delivery to the tissues. This is even true for patients with single ventricle physiology. Even in those patients, we would try to keep this balance of the QP-QS around 1, even if we have to accept a lower arterial oxygen saturation of about 85% in those patients. And so we accept the low saturation to maintain this balance of QP-QS of 1, which is the best situation to keep the oxygen delivery to the tissues at its maximum. So I will modify the pulmonary vascular resistance and the systemic vascular resistance to direct the blood where I want to go, where I want it to go. So I will play with the pulmonary vascular resistance and systemic vascular resistance to keep this balance of the QP-QS ratio around 1. And this is the rule of the oxygen, and this is the rule of the ventilation, and also this is the rule of using the nitric oxide to decrease the pulmonary vascular resistance, and this is the rule of using systemic vasopressors to increase the systemic vascular resistance in some patients. So these are the tools that I can use to keep this balance between the QP and the QS. Now talking about the ideal induction technique. There is nothing called ideal induction technique. It is according to the anesthetist preference. There is no standard technique to use. There is just a cautious anesthetist who use the drugs or the inhalation anesthetic agents carefully, who follows the monitor very strictly, and who deals with any derangement swiftly. So we have targets of FiO2, targets of ventilation, targets of hemodynamics, heart rate, and blood pressure, and we maintain these targets with whatever anesthetic we have. I have seen cardiac anesthetists use inhalation induction for very sick patients. I have seen cardiac anesthetists using propofol for very sick patients. It is just very cautiously using it, very slowly increasing the amount given, and monitoring the patient very strictly. So the induction techniques are very variable, and there is nothing called standard technique. Uh, Now talking about the airway, if you suspect difficult intubation, just prepare for it. Just prepare by like informing the team that you may have difficulty, inform your ODP or the technician who is helping you that we may have difficulty with this patient. We need to prepare stylet, bougie, video laryngoscopy, gyroscope, or CMAC, even fiber optic. You may also ask for help, another anesthetist to be around or with you during the intubation of this patient. It is not shameful to ask for help instead of having troubles. And because this patient is usually very sick, and this patient cannot tolerate less than standard maintenance of airway and of ventilation. So this is the patient that you don't need to have severe desaturation or high CO2, because simply this patient will collapse very fast. So the idea is to prepare everything and to keep everything ready and to avoid any of this. So the quotation that comes to my mind when facing a suspected difficult intubation case is as follows. By failing to prepare, you are preparing to fail. Regarding the airway, in most situations, microcuffed endotracheal tube is used. One, because of its reliability in maintaining the ventilation in case we need high airway pressure to ventilate a poorly compliant lung. Oral intubation is for large children, I would say about more than 2 years old, and also if less than this age, if you are sure that we're gonna extubate the patient at the end of the surgery. If this patient is going to PICU, so the PICU team would like nasal intubation. And this is because it is more secure, it is better tolerated by the sedated child, it is difficult for the child to push it out if the patient is on light sedation, and also the tape is away from the saliva, so it is less likely to be accidentally extubated. If we're gonna use the nasal intubation, there is some tips, some tricks. So having some snot in the nostrils can make troubles. So like the smallest amount of snot that can go into the tube can cause significant airway obstruction when you don't need that in theater. So we can get rid of any snot in the nostrils before inserting the tube by gently pushing the temperature probe into the nostril. The temperature probe has like a blunt end that we can just pass it through the nostrils, and it will clear the nose from anything before inserting the tube itself. If you are gonna use the gyroscope, if this is the first time for you to use a gyroscope for nasal intubation, just be careful because sometimes it is really tricky. So I would say if you want to use a gyroscope for nasal intubation for the tiny babies, it is better to use this for like the very stable, uncritical patients for some time. Just familiarize yourself with the view and how you're gonna hold the tube with the forceps, how you're gonna push it in, because sometimes it's tricky. The view with the gyroscope is a bit limited, and sometimes when you see the tip, you can't see the forceps tip. When you see the tip of the tube, you can't see the forceps tip, and it needs a bit of ergonomics, a bit of familiarity of what you're gonna do for this to maintain it. So you can get a very nice view with the gyroscope, because the gyroscope can see, especially the curved probe. You can have a very nice view of the gyroscope that you cannot get with the laryngoscope, but just holding the tube and pushing it in and seeing all these things can be a bit tricky. Um, so some cardiac anesthetists just prefer putting an oral tube first, and this is to give them an idea about the best tube size. So if they feel like the tube went very easily and the patient can accommodate a bigger tube, so you will prepare a bigger tube, and also to maintain the airway and to give oxygen and be sure that the patient is stable. And after that, they change it with a nasal tube in a controlled way. So, and this is to avoid any desaturation or any hyperventilation that the patient may not tolerate. So, when you have the oral tube in, put the nasal tube into the nasopharynx, hold it with the McGill forceps first, and when you are able to see the tube, the McGill forceps, and everything, we just ask the assistant to take the oral tube out and then push the nasal tube in. It is a routine in cardiac anesthesia to put a central line and arterial line and big IV lines. So the central line options are usually left and right internal jugular vein and the femoral vein. So you would ask about the venous cannulation technique, like the venous cannulation for bypass by the surgeon. So if the surgeon will use the SVC, so you may avoid the neck right internal jugular vein because sometimes the central line will be snared with the snare around the venous cannula, and this usually obstructs the line, and it would not be of any benefit during the bypass time. Femoral vein is good, but it will not give you the option to do anything after draping the patient. So not be able to reach the line after covering the patient, which would be a problem. Like if you missed a clamp or the line is obstructed or the line is disconnected. So in this case, it will be difficult to reach the line after covering the patient. Um, so in this situation, you just need to connect all the infusions, all the fluids, everything to the line before covering. And even if you are in doubt, am I gonna use this infusion or not? For example, I think about using like vasopressin or something like that. So just prepare it and connect it because it will be a bit tricky to connect it after starting the surgery. Arterial uh, line, the femoral is good. The radial is a bit less accurate, and it is also difficult in the tiny babies. The brachial can be used, but there is some concern about limb ischemia with brachial arterial cannulation. So regarding the need for extra lines, for some surgeries, like for aortic arch surgery, the surgeon will ask for upper limb and lower limb arterial line, and this is to compare the upper and lower pressures to see if there is still residual obstruction after the repair or not. In Norwood or stage 1 surgery of hypoplastic left heart syndrome, arterial line in the right arm will be of benefit to measure the cerebral perfusion pressure. At a certain stage of this surgery, we do something called selective cerebral perfusion, where the blood flow to all the body will stop and the cardiopulmonary bypass will be just connected to the subclavian, perfusing the brain and perfusing the right upper limb. So having an arterial line in the right radial or right brachial will give an idea about the cerebral perfusion pressure at this time. Regarding the postoperative pain, we have lots of options. We may do a block. We may ask the surgeon to give local anesthetic. We may use painkiller infusions, fentanyl, morphine, dexmedetomidine. We may use NCA or PCA according to the age of the patient. So our choice will depend on our expectation of when this patient will be extubated. If extubation is in theater, which we say is ultra fast tracking, or if the extubation is expected to be shortly after admission to the intensive care unit, a block or local anesthetic infiltration will be reasonable. Um, for another patient who is a complicated patient, expected to have a prolonged ventilation in PICU, so this patient will not be a good candidate for a block because the block will wear off while the patient is still under sedation or under anesthesia. Regarding the transesophageal echo, it is the size of the patient and type of surgery that help us to decide whether to use the TOE or not. There are three TOE probes: neonatal, pediatric, and adult. For a patient who is less than 3 kilo, most of us would avoid using the TOE because of the size limitation. And actually, if it is really needed, so the cardiology and the surgeon can use an epicardial echo using a probe covered and used in the field. For a patient who is 3 to 5 kilos, the neonatal size would be okay. For more than 5 kilos, the pediatric size can fit, and up to adolescent size. And when the child reaches or approaches the adult size, so the adult probe can be used. It is very useful to use the transesophageal echo, but it could be harmful as well. It can cause hemodynamic instability by bracing against the atria or bracing against the pulmonary veins, decreasing the venous return, and also bracing against the airway, causing problems with the ventilation. So we need to check the ventilation before inserting the probe and then after to see if there is any difference. We usually avoid the transesophageal echo in patients with total anomalous pulmonary venous return, so patients who has abnormal pulmonary venous flow, because the probe will or may affect the flow. It may obstruct the pulmonary venous return in those patients. Distraction is a big problem. You may be looking at the TOE and you may say, oh, why this heart is moving slowly, or why this heart is shaking like that, and suddenly you discover that the patient is in a problem. The patient is bradycardic, or the patient has VF and hypotensive, hyperperfused, while you are just focusing on the TOE examination. So just be careful. So distraction is a real problem, and the anesthetist needs to take it serious. The drugs we used and infusions are very variable from center to center. So at the last place I was working in at Alder Hospital, it would be adrenaline infusion, milrinone infusion, vasopressin infusion, tranexamic infusion. This is for most of the patients, unless the patient is very mild lesion or VSD, ASD, and we are not expecting to need adrenaline or milrinone. So in that case, we may decrease the number of the vasopressors and inotropic infusions. Phenylephrine and adrenaline bolus syringes are always available and ready for all the patients. This is plus the anesthetic drugs, antibiotic. Some of the anesthetists would use steroids, some would use magnesium, some would prepare the calcium from the beginning. In most centers, the bypass machine would have an isoflurane vaporizer for maintenance of anesthesia. So during the bypass, we are not able to give sevoflurane from our vaporizer. So if the machine, the bypass machine, has this facility, that's okay. We can use the vaporizer on the bypass machine. However, Tiva can also be used using a combination of propofol or midazolam and fentanyl or alfentanil or dexmedetomidine. Some people use rocuronium boluses, and some other anesthetists just put rocuronium infusion just to be sure that the patient is relaxed all the time. So from the preoperative assessment, we know if this patient is a good candidate for ultra-fast tracking with extubation in theater or for fast tracking with extubation within few hours in the PICU. So if this is our plan, so all the management will be targeted towards this goal by decreasing the total dose of opioids, by doing a block, giving paracetamol, giving anti-sickness medications, by decreasing the tissue edema as much as we can, and we take the final decision on the table at the end of the surgery. And if there is no surprises in the surgery, we can just go with the plan. ECMO is the machine we use for patients struggling to come off bypass because of a cardiac issue that we are not able to manage with medical support, or because of respiratory issue with no obvious surgical cause that we can correct before coming off bypass. Inhaled nitric oxide is usually prepared and used in patients with high pulmonary vascular resistance or patients with right ventricular dysfunction. It is sometimes predictable whether the patient will need nitric oxide or not. Its preparation takes time, and it is wise to inform the technician and keep it ready enough time before coming off bypass. Most patients will go to PICU, Pediatric Intensive Care Unit. Some centers have HDU that would accept the patient if the patient is extubated and stable.
Thank you for watching this important video. Have a nice day. Mariam Ali.